Welcome to a Shot in the Arm podcast. My name is Yvette Raphael.
And I'm Ben Plumley, and this is a podcast about innovation and equity in global health.
And this week we are in Montreal, in Canada, reporting from the AIDS 2022.
And our first guest for this podcast is my dear friend, Andy Seal, who is an advisor at the WHO. Andy, welcome to a Shot in the Arm podcast.
Fantastic to be here.
Yeah, it's really good to see you both here. What a lovely way to kick off. First question, elephant in the room. What's going on with the visas here in Canada? Yvette, what have you heard?
Most strangely and very sad, actually, Ben, because we have a lot of young people who've never travel naive, that were denied access to come to a conference that they can contribute so much into. And for me, the fact that so many Africans are left, so many African advocates are left, it's just heartbreaking. And I hope it's a lesson for the next organizers, not to make sure this doesn't happen again.
We say this every conference, though, don't we? Don't let it happen again. But I wonder, Andy, has WHO had any people had refused visas?
Sadly, yes. So we've also struggled. So it's obviously community and activists that we're mostly concerned about. Perhaps they don't have the same access to solid internet connections, for example, to participate fully virtually. But we're seeing all sectors who engage in this conference struggling to get here. So several of our staff from Africa, from Asia, sadly are joining us virtually. But I have to say, positive note, our colleagues are at least saying that they're feeling as though the virtual experience is a good one so far.
Good, well, we're getting our head around it, aren't we? Do you know, I was in the queue, a long queue to get into the plenary session today. I mean, it was going right, it was like Disneyland getting in. And in front of me, or a few rows in front of me, were two definitely North American delegates who said, Africans can't get visas but look how many Africans there are in this queue. Gosh. But it does speak that nonetheless, we do have a good turnout. I mean, what are we thinking? 4, 5, 6,000?
Yes, it's possible. And I think after such a long time of us not being together, everybody that could tried to be here. I'm also very impressed. I was on the stage and I was impressed with the number of people in the opening plenary. So people are committed, people are excited to be here.
Yeah, I want to know about the stage experience in a minute. But here we are, end of the first day. What's caught your attention, Andy?
I think the opening plenary, and I think the energy in the room, the fact that we did have community taking over the stage fantastically, super articulate. We've missed that energy, we've missed that activism, we've missed connecting to friends, we've missed, really the fantastic vibe that we get when we come together in these conferences where really, people we're connected by a disease, but it's a bond, and I think that when we see people that we haven't seen for months, it re-energizes us. And it reminds us why we're here and why we do the work that we do on a daily basis. So I think that personal connection, the activism, for me, is the key thing about this conference. It's the connections and it's the community voice. A community voice came out super loud this morning.
Oh yes, it certainly did. Yvette, you just said you were on the stage, and indeed you were on the stage. Had you been invited on the stage?
No, I hadn't. I wasn't invited. I think most importantly is the fact that activism is alive and activism is a spur of the moment thing. Activism is there, and I was carrying the ring light, and people thought it was part of my planning for this conference and not. I needed to make sure my voice is heard, the voices of women that I've left in Africa is heard. So I am just glad that activism is alive and it's kicking, and I'm happy that activists took over their stage, not a stage. That's our stage.
And it was super smart for you to take that ring as you did. I took photos, I've tweeted it. I mean, what a better way, when we're finding out that there's 1.5 million infections still last year, we need more prevention options available to more people.
And choice.
And choice, exactly. So the long-acting injectables now for PrEP as well is an additional prevention option. You asked me highlights so far. For WHO, that's one of our highlights. And to see this really being called for by community in that stage invasion was just fantastic.
So just explain to us what the ring was. What ring were you carrying and why were you carrying it?
I was carrying the Depivirine ring, and this was because funding for this ring is just dwindling, and I think funders are a little bit not sure should they fund the ring because of the fact that FDA hasn't approved it, or FDA didn't play a part in its approval, and it has such a negative effect that some of our countries, our Department of Health, our MOHs, are not that confident because, remember, I always say, when America coughs, South Africa or Africa gets a cold. So everybody's now worried. Why is USAID, why are some of the funders not behind the ring? So it was a reminder that we need to fund the ring because African women want the ring. And until we have these studies confirming that either women don't use it or we use it, can we make a decision to invest more or to pull out? Now it's not the time for USAID or any other funder to pull out of the ring.
Now, just to be clear, the ring is a microbicide. And for folks who aren't necessarily involved in the AIDS movement, it's worth just explaining what a microbicide is.
Yes, it's an HIV prevention method, right? And this ring is induced with some Depivirine inside the ring, and you can keep it in as a woman for 30 days and remove it, and you are prevented to getting HIV. So that is what we're excited about, and that is what is important for us to know, is that evidence show that it's up to 65% effective, and it's important that women start getting that access to that.
Now, I'm interested in you saying that 65%. We'll come back to that. Andy, what is the WHO's position on the microbicide ring, the Depivirine ring?
Well, I mean, certainly WHO is continuing to advocate that this is another prevention option. For us, the critical factor is it's a female-controlled tool. You know, women need more options, you know, to help them protect themselves around HIV and sexual reproductive health and rights. And any attempt to create barriers to options that have any level of efficacy, frankly, it's not helpful. You know, when communities are smart, they're self-informed, they understand. We know that for prevention, you often need a package of tools, and taken singly, they're not necessarily going to provide that you know, silver bullet that we talk about sometimes, but you combine a few different methods, and every time you add something else on, whether it's a behavioral aspect or whether it's a biomedical aspect, you know, you add these together and then you get greater protection. So again, it doesn't make sense to take one of these options away just because we can't stand up in a conference and say 100%.
Nothing has ever been 100%.
Absolutely.
I mean,
even condoms, right? I mean, you know, if you're trying to
100%.
protect from pregnancy, we know condoms are not going to be 100% effective.
Well, and especially if you follow the guidance of certain right-wing churches and put holes in them. But you mentioned 65%, and you're talking 65% efficacy in women preventing HIV infection. But the trials to date haven't shown that, have they?
Actually, they have, but we are downplaying the studies that show that after anybody don't trust any method that's in studies. So after the first announcement that it was 35% effective, and we went into open label extension studies, women then started believing in the product, and the efficacy will go up. I am sure of that because women want this product. Who wouldn't want a product that they can control themselves? And it is you know, it's discreet, they don't have to use it, they don't have to worry about changing it every day. It's 30 days, and who wouldn't want that? So let's give it a fair chance, as we have given to any other method in the field that came in.
Absolutely.
But our problem here is that the US FDA, looking at that clinical trial data, concluded that it couldn't approve the microbicide Depivirine ring. And because they didn't approve it, as I understand it, US funding through USAID and PEPFAR are not able to purchase the ring. Is that right?
Not entirely true. I'm the doctor activist because I try and find out all of these meanings. And what the FDA did say is that it is not relevant for their disease in the US. So we can, in their context, so they did not, it wouldn't help them to approve it or not, because they weren't going to purchase it. However, the narrative has been pushed as if the FDA said they wouldn't approve it for use anywhere in the world, but it was because it is not. And African American women can argue that that's not the case, because they are the ones who also want this ring. So we're not only advocating for African women, but African American women too.
So why did the US decide not to fund it in global access programs?
Because of the FDA's decision not to support it.
Well, that tells you something, Andy, doesn't it, about our global approval mechanisms. What do the WHO think about the kind of approvals that are needed? I know this has been a hugely controversial area. We have the pre-qualification processes for antiretrovirals and for some diagnostics. But the WHO is not a global approval mechanism. So how do we get around things if the FDA won't approve, but we need the product in resource-limited settings?
I think the WHO's role remains critical, and again for the other settings in particular, I think it is absolutely critical. So, for example, some of the big funders, they'll be looking at purchasing strategies, and they often look to make sure that there is pre-qualification through WHO to give them a green light and feel secure that they will get enough demand coming through, whether it's a PEPFAR mechanism or a global fund mechanism. Similarly, there are, when it comes to domestic regulatory authorities, they do look to the FDA. Of course, they look to the US, but they also look to WHO. And obviously, some countries don't have that same trust relationship with the US. Let's be fair. So the WHO role is a really critical one. We're not always in sync in terms of time frames, but we're often aligned with authorities like those in the US, who also invest heavily in the research and making sure there's a robust process. Because of course, it's critical we have quality products. It's critical that we have products that are available and accessible and acceptable by communities as well. So if you're going through that kind of regulatory process, which we increasingly do at WHO, increasingly involve community input into our thinking and our processes, it just helps make sure that when we get to that point of rollout, we're going to be able to do that speedily when our financing partners also join.
Other scientific advances that are catching our attention, you mentioned it briefly, long-acting in antiretroviral medicine that's, how shall I put this stupidly, in a liquid rather than a pill, and it has to be injected, mostly through the buttock, unfortunately at the moment. So long-acting injectables for HIV prevention and treatment, this is certainly a disruptor. Will it be a game changer, do you think?
So for WHO, we're delighted that one of the big things that we're announcing this week, in fact, I think we've just announced it, is we have some new guidelines around long-acting. I have to quickly check. Cabotegravir. I always get the B and the T confused. Long-acting cabotegravir. This is for PrEP. So this is a prevention tool. So we haven't been through a process yet to explore long-acting injectables for treatment at WHO, but we have been through this process now around long-acting PrEP. As you say, it's an injection every 2 months. It's another prevention option. We talked about already the importance of having options, particularly for people at risk, personal choice, but potentially as well. And also, potentially for women as well. All risk groups, including young women in Southern Africa or Sub-Saharan Africa, have been involved in various trials and research approaches. So it's looking promising. You saw today that there are big questions about price and access, and activists are focusing in on that, as we would hope and expect. And really, from a WHO point of view, we're really looking now at more operational research, implementation science, to really help us understand, is this working in the way that we hope it will, making sure obviously there are no unintended risks that are coming out of its use.
So you're talking about PrEP. And that's where the WHO has got to. But of course, it is approved in the United States for treatment as well. And if I do my pitch for the San Francisco Community Health Center, which I'm the president of, we've just started providing long-acting, both PrEP and treatment for, basically our clients are homeless, they are very much marginalized, mental health problems, injection drug use. So it is a very interesting moment. But the access. So I know you've got a few views on this.
Yeah, most definitely. And I think as Andy was speaking, I was just thinking, the price. It's very expensive. Andy, let's talk about the price. It's too expensive and it will not become accessible. There's issues around the testing modalities and algorithms and how to test for you to be able to access it. And those are the questions that we wanted answers for in the early stages of this research, and we are excited, we are happy, it's another option. We want women to access it. Actually, we want women to access everything, because these methods, these studies happen on the backs of black women in Southern Africa, in South Africa, in Uganda, in Zimbabwe. So there's no reason why we should not have access to these methods. And it would be criminal if we don't, but can we afford it? Can Kebele go down to the prices that our governments can procure? And so we look again into our funders like USAID and Global Fund to take the lead and procure this. But I also want to just commend WHO, and I'm not saying this because Andy's here. I'm a special shout out to Rachel Bagley. Yeah. This, after the announcement by FDA around the ring, Rachel Bagley still stood by the decision by WHO and what the guidance said about the ring. So it's important that we recognize that our allies are sometimes in these elephants in the rooms.
Yes, but it is funny that I think over the course of the last 2.5 years, the COVID pandemic, something extraordinary I think has happened with WHO, or the perception of WHO, rather than being slow and overly bureaucratic. Despite maybe a few rough starts at the beginning of COVID, under your boss's leadership, Dr. Tedros, I mean, you really have been at the front line. And I think that's absolutely epitomized in Rachel Bagley's leadership. And it says something that people like Rachel can truly lead. And we're going to learn a lot more about long-acting during the course of this week. And I know Yvette and I have got podcasts, so make sure you tune into those. The other thing I wanted to get both of your views on was the UNAIDS report. UNAIDS always issues a global report just prior to these conferences. And this year was no different. And they presented a report that was actually very stark, very concerning, and indeed in the title was danger, that after COVID, given the economic confusion that we're in and the geopolitical crises that we face, we're really not on track to meet the objectives that we've set ourselves for supposedly ending AIDS as a public health threat. Andy, WHO is part of UNAIDS. What are the things that you took out of that report that you think our viewers and listeners should really know about?
Well, I think first of all, the response was stalling before COVID, and I think we need to be, we need to make sure that we do not rewrite the narrative around, some of the failings that we collectively, I'm sorry to say, have to share responsibility for. This was stalling before COVID, and for lots of external reasons as well as perhaps some internal reasons. Hindsight's fantastic. We can look back and we can think about different ways we might have messaged, different ways we might have targeted funding, for example. But the critical thing is we were stalling before COVID, and COVID has made things a lot worse alongside the war in Ukraine and climate change. All of those are the competing priorities. The economics of exchange rate shifts and moves, as well as compromising some international mechanisms that help get money out for the response. But the basic figures, Ben, are quite alarming. So I'm actually in support of the quite stark danger, branding, if you will, of this report. 1.5 million new infections in 2021, the same as in 2020. 650,000 HIV-related deaths last year, the same as the year before. It's shocking. It's absolutely shocking. We've all been working in this for decades, and we've really slowed down. And I think in real terms, we may have even taken a step back. So again, only half of kids who need treatment are accessing treatment. So there are some stark, data points within this report that we have to take seriously. I do think UNAIDS have messaged this one correctly. It's a difficult message to get across because we have all invested time, money, and energy over the years. So it feels very disappointing to say the least. But we have to also remember that we've collectively again saved millions of lives. We have. The response has not been a failure, but we've not carried on with that same energy and projection that we had previously. We saw some of that energy this morning, so let's get all of that back. And I think that's what UNAIDS is trying to do with this call. They're really trying to mobilize again and get people re-engaged.
Yvette, your take on the report?
Yes, obviously, I totally agree with it. And what I am happy about is that UNAIDS, as the political leader in the fight against HIV, is taking the lead. And I'm actually hoping they hold themselves accountable for where we are, because it's important that we all, like you say, we all take account and take stock where we went wrong, but also remember when the COVID announcements came and COVID came in, advocates and communities warned us that if you lock us up, what's going to happen to our treatment? What's going to happen to some of the things that we are used to doing? How do we prevent HIV? How do we get our condoms? And our governments were just not listening. And I think out of shock, UNAIDS also set back. And so they're taking responsibility to say, okay, as the political leader, we know we're going wrong, but I think we still have an opportunity to catch up. I'm just not happy that the face of HIV is still women. I'm not happy that it's still young women. I'm not happy that it's still black women in Africa. Mm-hmm. So we need to do something quick and fast. And I'm very, very happy that we are starting to talk about the new, HIV prevention methods. And those are the only things that can help us. Listen, talking about our stories is not going to help us out of this.
So I have a sort of slightly different take on it to you two. And I people who know me from the mid-teens onwards knows that I was very concerned about the way, almost triumphantly, UNAIDS was saying, oh, we'll end AIDS by 2020 and it'll be completely over by 2030. And there was no way that was going to happen. So it's sort of nice that there's a touch of realism here. But on the other hand, what I worry about with much of our public health messaging is that we are determined not to let facts and science get in the way of a good story. And what I worry with this, and you pointed to it, that we don't lose sight of the achievements that we have made. And I think totally pragmatically, and I apologize if I appear too much like an English conservative politician at the moment, but I think our job here is to convince people that we need to keep investing in AIDS and that it is a worthwhile investment, and that if we do that, then we can perhaps get to some point. I don't know that we're going to end AIDS by 2030. I think that's nonsense. But we are going to get to a point where it becomes much more manageable.
Yes, and invest in people. I think the biggest mistake right now is that we are not investing in people. So the things that worked in the early days, the good stuff, like the peer education work, is not important. The community healthcare work is not important. We need to continuously fund those programs, because those are the things that help us get here. And once we slack there, even if you can have all of these methods available and no one telling people and encouraging people to take them, we will be back here again after 10 years. And like you say, Ben, every day the same thing. Every day
the same thing. Which leads us on to one of the other big stories bubbling under. Will we get an announcement from Canada that they're making a huge investment in the Global Fund? Fingers crossed. We've got the Global Fund replenishment, and we've had some fantastic commitments from the United States, 30% increase, but for the US to make that full commitment, we need other countries to step up and make that commitment. Germany has increased, but not at 30%. Sweden is about even. But France and Britain, where are we? And I suppose I'm going to have to speak to this. I know you've got an English accent, and you and I go back, which we need to talk about. And I won't press you on what the UK is, so I'll answer that. But Yvette, rubber hits the road. What do you think of how replenishment is going?
I think I almost want to say it's hypocritical for the US to make a commitment like that and flatline on all the work they've been doing. I mean, come on, really. We are activists, we are not dumb. So let's be real. When we talk about the replenishment, let it be real investment, an investment without taking away from somewhere else. So where we are as countries, I think many more countries needs to come on board. However, COVID has done so much damage in the pockets of most countries, and we will just have to wait and see. But I would like to urge countries to continue replenishing and make sure that the Global Fund is funded and there's enough to do the work that we need and enough to actually get to do the AIDS work that we have to do.
So again, I'm going to disagree with you slightly because, of course, as you now know, I live in California. And a number of our politicians, local politicians, are at the forefront, the leadership of the United States, yay. But I think that $2 billion commitment is new money, and it's a big commitment at a time when we're coming out of COVID. There's a massive investment, rightly so, in Ukraine, both humanitarian and military.
So we have money to fund the ring, Ben?
Well, that's a good question, isn't it? But it's not a question of money, though, is it? It's a question of approvals.
You can say whatever. Let's agree to disagree on that one. But I know it's more money than anything.
Yeah.
Yeah.
Well, I mean, the way that I want to leave it for today on the Global Fund is a plea to our colleagues in the United Kingdom, and particularly the two leaders of the Conservative Party who are battling it out to become the next Prime Minister. Please, please, please replenish and increase by 30%. There's one other big topic that's happening at this conference, and it's not HIV. It's monkeypox. And it's sending a chill throughout this community. And Andy, you've been really a very public face of WHO on this, and I've really got to commend you for the way that you have brought this alive and provided, you know, accurate and intelligible information in a way that is reassuring. But could you talk a bit about the spread, the vaccination, the treatment? What's been going on? What's the science here?
Thanks, Ben. First of all, let me first comment on linking what you just said about you know, my involvement in this, and also previously about Rachel's involvement. And you quite rightly, both of you, pointed out that Tedros is facilitating this. We've got a new culture in WHO of really empowering people who are connected to communities to really be playing more of a role in helping to, you know, to communicate and also develop the approaches around different challenges. So I just wanted to say that quickly. Shameless plug. Thanks, Dr. Tedros. I think you know, internally we're doing some things right, which I'm very happy about. In terms of this disease, monkeypox is not new. This has been around for 40 years or more. Previously affected countries, I think there are 7 or 8 in Western Central Africa. It's in those countries, it's a zoonotic disease, which means it can easily transmit from animals to humans. And what's tended to happen in the past is you might get, you know, a case where somebody has consumed some contaminated bushmeat, for example. They get an outbreak. They might infect people in their immediate household. It kind of burns out, and you know, and move on, kind of thing. There have been outbreaks internationally linked to travel to Western Central Africa over the decades. There was even an outbreak in the US linked to animals. I think at one point pet rodents were brought in from West Africa that were sold on the market here as pets. And that created a small outbreak some years ago. So we've got knowledge and understanding of how these limited outbreaks, and they've been very limited in the past, have have occurred. What's different with this one is really the speed of this outbreak. It's really travelled. I mean, we've now got, I think, around 20,000 cases in more than 70 countries since April, or since the beginning of May. So from a very few reported cases in Spain, in Europe, we're now looking at a global emergency. And obviously, it is now a global emergency because our emergency committee met twice. The last time was last week. And as a result of that meeting, of that committee, Dr. Tedros looked at the deliberations from that meeting, and he did declare a public health emergency of international concern to help mobilize resources. Going back to your question, Ben, predominantly when we look at the data, the majority of cases are in men in the newly affected countries. So 99% are in men, 1% in women and children. And of that 99% of men, where we have data, which is in most of the European countries, for example, around 98% of those men are reporting as either gay, bisexual, or other men who have sex with men. So where we've got data, it's very clear that this outbreak is quite confined within a specific community. So that community at the moment, and it could spread because there are multiple modes of transmission. This is not, at the moment, we're not describing this as a sexually transmitted disease. If you remember Zika could be transmitted through mosquito bites as well as sexually. For monkeypox, you can have close skin-to-skin contact. If somebody's infected or they have lesions on their skin, in their mouths, you can transmit through kissing, through mouth-to-skin contact, etc. So you need to have quite prolonged, close and intimate personal contact for transmission to occur. And in this outbreak, it's clearly entered into sexual networks of men who have sex with men. Those sexual networks are quite dynamic. They're well connected. They connect cities and countries. And yeah, if you think about it, if somebody has perhaps more than 3 sexual partners a month, which some MSM, some men who have sex with men, do have multiple partners, it's quite easy once a virus gets into a network like that for it to continue to transmit. I should say it's not limited to men who have sex with men. The messaging around this one is complex because, of course, we want to target the resources appropriately for the response. We want the community, we want to continue to support the community who is being super active in responding to do the right things. So again, community leadership is fantastic here, but we also have to keep interrogating the data, keeping an eye on the data, and there are cases, limited cases, but nevertheless we cannot ignore the fact that there are cases in women and children as well. And sadly, we've learned today that there are the first deaths being reported in the media. They've not been confirmed yet. I suspect that will come over the next 2 days in terms of confirmation through WHO sources. But we're hearing that there have been the first deaths in Brazil and in Spain.
A lot to break down.
A lot
here.
going on. Sorry, I spoke a lot there, Ben.
Oh, it's fine. First question, you spoke that it's really primarily about men who have sex with men. Yep. So that's gay men, that's bisexuals. Presumably that also includes trans people as well.
It does, yes. So again, we have to look at the sexual network, and we have to also understand who's having sex with who, how. So for example, within the trans community, there are many trans men will identify as gay, so they're automatically part of that sexual network. Similarly, trans women may also be connected to that network through bisexual men, through other men, through sex work. So again, I think you're right. We have to really be careful about our messaging, but more importantly as well, our approach. We need the services to get to all of the people that really need them. And we need all of the communities who may be at risk to be, be aware of the symptoms, remove yourself from social and sexual contacts if symptoms develop. That's the simplest prevention message.
So I think this brings us back, we're sort of, we're barreling forwards towards the past. This feels, you and I knew each other in the late 80s, early 90s. Yeah. We grew up in a world of AIDS, and I'm feeling there is so much that is similar. There's a lot of difference, and we'll come on to that. But here's my concern. We are trying to balance not creating an atmosphere of fear and stigma and discrimination. But because of this language that we're using, and I want to come back to you around the use of what we mean by sexual networks.
Right.
You know, are we really telling people what they need to know? And Yvette, you have been really at the forefront when it comes to HIV and telling people what they need to know. How are you feeling about how information about monkeypox is being given to folks?
Very stigmatizing, first of all. And I'm glad, Andy, that you spoke about the fact that monkeypox have been here and we haven't, the attention was not there. So me sitting out from the outside, African women thinking, oh, it is the white men again. So it gets attention because it's in that community. But then again, as an activist who do not advocate for a gender, I then immediately go back. If this community is seen as the community where this is happening and you articulate that so well, are we going to get the HIV stigma against gay men? Are we going to get it against the community? Are we going to get it against my friends, the people that I love so dearly? And that is what you are talking about, Ben, the importance of language, the importance of how we actually transmit this information to people and what they need to know. But I'm just worried about my friends and my community not to be stigmatized and people to live free and have all the information, and so that we can make decisions not to be infected. I read this morning, and the media, we need to have media cafes again because the media are the ones. This morning I read WHO encouraging gay men to have less sexual partners. And I was like, this is AIDS all over again. This is 40 years back all over again. And it's unfair unless we do something about it real quick, real fast, and make people understand their own risk. Evaluate your own risk.
You're absolutely right. I think there were a number of things. We had a fantastic community conversation earlier today, actually, with a lot of gay and bisexual men from all over the world, really helping to think through exactly these questions. There are some obvious kind of like prevention messages. You know, fewer partners equals lower risk. We've been saying these messages for, as have community groups for.
You must just have fewer partners, but if it's fun.
No, we're absolutely not. Listen, we're not saying. What we're saying in our messages is exactly what you've said. Individuals must take their own risk assessment, and it's not one thing. We're not saying don't have sex. We're not calling for sex venues to be closed, but there are things that sex venues can do. They can facilitate exchange of contact details. They can encourage the exchange of contact details so that should follow-up be required by anybody who's visiting that venue after an outbreak or after cases have been reported, people can act fast, so they're able to respond rapidly. So they might need to do an alert in the local community. Again, it doesn't have to be through mainstream media. You know, there are ways that communities can talk to each other without attracting that awful commentary that is frankly homophobic and often racist. And the other thing that I can say, Ben, is that there's a solidarity issue here as well, that it's very much like HIV. This affects 7 or 8 African countries, Western Central Africa, that have been neglected. We've not had a spotlight on it, as Yvette said. We really need to focus resources into those communities as well. Those communities are absolutely deserving and need our support, the same kinds of approaches as the newly affected countries. And you would have heard Dr. Dimitri and others today as well talking about the fact that the same things are happening around the inequities and inequalities within those communities. So it's people of colour and it's people who have no access to resources that are going to be left out of testing, vaccines, access to antivirals. We have the tools to help manage this outbreak. Really sad to hear about the 2 deaths today, shocking. But at the same time, it's not the same as what we were seeing with HIV.
It's not HIV.
Yeah.
But I mean, there are 2 things that I reflect on. One, there is, bringing it back locally to the Bay Area of San Francisco. There is an East Bay bathhouse that is the primary provider of vaccines, monkeypox vaccines, which I think is terrific. Yeah. The other thing that I'm feeling anxious about is that this is a this really highlights, I think, the weaknesses of our public health systems, plural. We certainly see it in the States, but coming so soon after COVID, we're tired, right?
Yes, we're definitely tired, but when COVID started, we were already planning for the next epidemic, and monkeypox hit us, we were still not ready. So what really needs to happen is for us to take health seriously and for us to really have a task team to talk about pandemics and really involve community. I think the biggest mistakes we keep making is not involving the community in the earliest stages of any discussion.
Community has to be diverse and representative.
Exactly.
Because again, I have to say, and you guys will know this, and I'm just being very frank here, global agencies, we can get lazy. We can pull on the same faces to advise us because we've got nice relationships with them, they become our friends, and we have safe relationships. We don't need safe relationships to get on top of health crises. We need to be challenged, we need to challenge each other, and we need to, absolutely, and we need to make each other feel uncomfortable. But in a good way, if that makes sense. We need mutual accountability.
Yeah.
We need to hold each other's feet to the flames on these issues.
And I think that's something we're going to see if we've got this week at AIDS 2022, because I am not convinced that we are mutually accountable. So look, we're coming to the end of this podcast. What have we missed? What are the key things that you think we need to know this Thursday afternoon in Montreal, Canada?
Goodness.
There's a lot, Ben. I think for me, apart from Cabaret, apart from the ring, is also just the gap in community workers, the fact that community workers still continue to be unpaid. I think a lot of how do we do community engagement better, and just how we as a global community have to continuously fight and get together to make sure we get to some point where not an end to AIDS. I always say, that was the most dangerous slogan we could ever have started, an end to AIDS. But make sure we bring new infections down in adolescent girls and young women, especially in Africa.
If I can compliment without contradicting, because I totally agree with you, but I think in addition to that, 650,000 deaths last year, it's shocking. It's tuberculosis, it's cryptococcal meningitis. And so for us at this conference this week, we're also bringing new guidance and new energy and focus onto what needs to be done around cryptococcal meningitis. So I think, again, if my last take-home message and the things that we're keen to see really be adapted and taken up seriously is, for the authorities to really take a strong look at what's happening around HIV-related deaths, and that really does mean tuberculosis and cryptococcal meningitis. And we now have new guidance on the latter from WHO. Support us in getting that rolled out, implemented from communities as well.
And invest in health systems,
Right.
strengthening. And some of our countries just do not know how to handle this.
No, and then for me, related to that, and I can't believe I'm saying this, having been an AIDS exceptionalist, as you well know, Andy, for many, many years, I think this is about we are in the age of pandemics, existing, new and future. And so I wouldn't want us coming out of this conference without thinking about malaria and the opportunity that we have with new bed nets, with new vaccines. So we're all in this together. Well, I guess that's it for this episode. Thank you, Andy, for joining us. Yvette, any final words?
Yes, you are wearing a beautiful, beautiful shirt made by Posy, and I think the future around investing in positive women and making wealth for their children and for their communities is important, and that's entirely just why I do it.
And actually, what a lovely way to wrap up. We didn't prepare that at all, but yes, I'm wearing an outfit produced by Posy, which is a company that Yvette set up. It's a self-empowerment group of positive women in South Africa. Posy has been a sponsor of some of our podcasts, including the Business Fights AIDS series.
Yes.
So yeah, it's really good to have Posy here and present.
Yes, we're not always coming with a begging bowl. We want to show that we have talent and we have business ideas, and our kids' future depend on our ideas and how far we can go with this. You're looking stunning.
I am looking
fantastic.
I am. And you know, the other thing is that I don't feel that I'm sort of, appropriating African culture.
Yes, and you don't look like the old white man with the dashiki. That is super, super cool. And
Yeah.
that's the idea behind Bozi, is
Yeah.
that we want to just make everybody feel cool in an African print without feeling like they're appropriating anything.
Super. Well, thank you all very much for joining us. Yvette and I will be back tomorrow, round about the same time, with some really interesting conversations around long acting and where we go with it. Just again remains for me to thank Andy Seal from WHO, and a final shout out to everyone at WHO for the extraordinary work you have all done these last few years. You can find us on all your favourite podcast platforms and on our YouTube channel. Don't forget to subscribe and give us 5 stars. Have a great rest of the day and a safe rest of the day.
Thank you.
Thank you, Ben.
Thank you, Ben. That was great.